Hello and welcome to this session on tackling the inverse care law in general practice, analysis of policies to improve general practice in deprived areas in England since 1990. My name's Lucinda Allen and I'm a policy officer at the Health Foundation, and this work was co-authored with Bex Fisher, Mimi Malhotra and Hugh Alderwick. So today I'm going to cover an overview of the inverse care law in general practice, the aims and approach of our analysis, and then our findings and implications for future policy. So in 1971, Julian Tudor Hart set out that the need for and access to healthcare was not equally distributed among the population. And his inverse care law holds today, including in general practice in England, which is the focus of our work. Our previous work at the Health Foundation has shown that compared to more affluent areas, general practice in areas of high deprivation in 2018-19 had higher population health need, higher consultation rates, received less funding, had fewer GPs and shorter GP consultations. So taking practice payments as one example of this, once weighted for need, in 2018-19, practices serving more deprived populations received around 7% less funding per weighted registered patient than those serving more affluent populations. And why is this? So around 50% of funding of most practices comes from Car Hill, which doesn't include any adjustment for deprivation, which we'll talk about shortly. And on almost all other income streams, such as QOF, so incentives for quality of care and payments for locally enhanced services, practices in deprived areas average less income. So past governments have used various approaches to try and make the provision of general practice in England fairer. Our analysis aimed to answer the following questions over 3 work packages that you can see on the screens now. So since 1990, firstly, which policies have attempted to tackle the inverse care law in general practice in England? And for each of these policies, what were the mechanisms used and the targets set? And then secondly, what were the results of these policies? Were they implemented as planned? What were the outcomes? Do we have any evidence of their impact of either these individual policies or groups of policies over time? And finally, what can we learn from this, if anything, to inform policy in the future? So in terms of our scope, we are focusing on national policies introduced by central government in England, rather than considering different regional or local policies. Although we drew on some evidence from other countries where relevant to make our broader conclusions, we focused primarily on evidence of these specific policies in England. We used 1990 as a starting point because legislation at this point introduced major reforms to the general practice and wider healthcare system, and policies before this, so they're less likely to be relevant to the current system. And if we started any later, that would also limit our findings to just 2 periods of government. And we are focusing on policies to improve the supply, or as we understand it, the access and quality of general practice in deprived areas. So not those policies targeting demand side factors. So for example, wider policies on health inequalities, such as smoking cessation, although obviously acknowledging that these supply side factors may influence demand. We also focused only on policies which aimed specifically to improve the equity of general practice, although we also recognize synonyms for this in policy papers, for example, where improving recruitment in so-called inner city areas was an explicit policy aim, and recognizing also that there were other policies which indirectly affected the inverse care law in general practice, though these aren't in our scope. In terms of our approach, we used a combination of data and methods to identify policies addressing the inverse care law in general practice. We reviewed government documents such as white papers and reviews of policy developments, and we consulted with experts who were involved in the implementation and analysis of policy at the time. And from this, we developed a database of national policies since 1990, summarizing data on their aims, components, and mechanisms to achieve impact. And then to identify evidence on implementation and impact, we searched bibliographic databases of published literature and government websites. And then we synthesized this evidence by domain including policies on funding distribution, workforce, premises, and commissioning and contracting. So moving on to our findings and the implications of those. So over the past 3 decades, we found that a mix of approaches have been used by national policymakers to reduce social inequities in GP services. They're outlined here, but in the interest of time, I'm going to focus on just some of those proposed policies. So the level of funding clearly has a major impact on what general practice can deliver. National policies aiming to address the inverse care law, though, through equitable funding have been somewhat limited. So there's a complex mix of funding streams, some of which I've already mentioned for general practice, but most of this comes through the core GP contract. A new contract in 1990 included deprivation payments to increase funding for GPs with more patients experiencing deprivation. So the calculations for this were based, for example, on patients' employment and housing. And these payments were removed in 2004 when a new Cahill formula was introduced based on GP patient list size and adjusting for things like need and morality, but with no specific adjustment for workload associated with practicing in areas of socioeconomic deprivation. There is evidence to suggest that the Cahill formula underpinning general practice does not adequately adjust for care need associated with deprivation, but policymakers have repeatedly promised and failed to change the formula. So on the workforce distribution has been used as a key policy lever. So national policies to make GP workforce distribution more equitable firstly involved changes to central controls on the distribution of GPs. So these have been in place since the start of the NHS, whereby GPs wanting to move practice had to apply to what was known as the Medical Practices Committee, or the MPC, who could then reject applications to work in areas that it deemed to already be adequately doctored. But then the MPC was abolished in the early noughties with the apparent or explicit aim of improving equity. And since then, policymakers have focused more on incentivizing GPs to work in certain areas or to remain working in certain areas. So this has been introduced through both changes to contracts and also additional payments and funded training with different programs over the past decade or so to support various groups, for example, GPs from outside the UK or returner GPs. And then finally, under Labour governments of the late 90s and early noughties, a mix of policies were introduced attempting to improve the provision of general practice in deprived areas, including investment in new and improved GP premises under what was called the Equitable Access to Primary Medical Care Scheme. And this was with the aim of encouraging GPs to work there and improving access. So data on the effects of individual policies are limited, but we have some evidence of the success of certain approaches. So regarding funding distribution, there is evidence to suggest that deprivation payments before 2004 redistributed some funding from London to deprived areas of Northern England and succeeded in targeting payments to general practice more precisely. And then regarding the workforce, Goddard et al. Found that central controls on GP distribution likely increased equity in GP distribution in the 1970s, 80s, and 90s, and that then GP supply became more inequitable after the MPC was abolished in 2002. And then finally, there's good evidence that the EA PMC scheme that I just mentioned and other Labour policies in the noughties appear to have contributed to the distribution of GPs becoming more equitable by 2010. So I've got some charts to show this. So looking at changes in the distribution of GPs in relation to deprivation over time, overall available data suggests that inequities in the distribution have persisted over the past 3 decades, but that there have certainly been periods where these differences have narrowed. Inequity in GP supply relative to population need grew between 1994 and 2003, despite overall increases in GP numbers. And then in the noughties, this pattern started to reverse. And by 2011, the most deprived neighbourhoods had the most GPs per need adjusted person. So there is a suggestion that policies in the 2000s may have had some success in contributing to a more equitable supply of GPs in England. But these improvements haven't lasted. So from 2015 onwards, there have been fewer GPs per patient in deprived areas than in affluent ones. So thinking more broadly, we can see that policy developments have not been linear, and they've been implemented in the wider context of approaches to NHS reform. So there was much less policy focus, for example, since 2011. Whereas in the late 1990s and 2000s, Labour governments introduced targeted measures to improve general practice in deprived areas as part of a wider strategy to reduce health inequalities. This included, obviously, the changes to GP contracts and building new GP surgeries in deprived areas. And although evidence on their effect is limited, it's likely that they contributed to more equitable distribution of GPs. Secondly, many policies have been small compared to the scale of the challenge. So, for example, in recent years, since 2015, there's been a focus on very time-limited recruitment incentives, as opposed to the national controls that had been in effect up until the early noughties. So, thirdly, we didn't focus on the wider policy context, but clearly this shapes the impact of policies. So, for example, cuts to funding for the NHS and other public services in the 2010s, 2010s will have had an impact. And then finally, as I said, evidence on policy impact is mixed, but there is evidence of success in the noughties and evidence that Cahill is inequitable, which which does suggest that some measures have been successful and that some other policy levers have been underused. So, drawing on this, what should national policymakers do today? Firstly, addressing disparities in the provision of general practice should become an explicit national priority set by government. It should form part of a broader national strategy to reduce health inequalities with clear goals for improvement and for measuring progress. Secondly, government should introduce an equity test for any new policies on general practice, to consider how the policy might impact equitable provision and how it will interact with other policies in place or being introduced at the same time. Thirdly, there should be an independent published review of GP funding allocations, including examination of different funding streams and alternative approaches to more fairly allocate resources. Integrated care boards should also be required to develop plans for reducing inequities in the provision of high quality GP services. And integrated care boards should also produce plans for data collection and to effectively monitor general practice provision relative to need. Importantly, as part of a comprehensive workforce strategy for general practice, government should also work with NHS bodies to consider mechanisms to more equitably distribute the GP and allied health professional workforce, which is something that has been underused so far. And as part of this strategy, government should also consider reintroducing stronger central coordination and oversight of GP distribution in England. And this could be done either at a national level or more locally at ICS level. And then finally, we need better, more consistent and publicly available evidence on the impact of general practice policies. Thank you very much for listening to this presentation, and I hope you all have a good day.